Good morning or good afternoon, everybody. Welcome. This is the Vaccine Mandate Update and Tools for Compliance webinar. We want to thank Charles James and North American HMS for sponsoring this today. Today's date is January the 6th, 2022, not 21. I gotta fix that, but I keep doing that. I'm Mark Lynn. I am a CPA. We've worked with Rural Health Clinics for a long time. I know some of you guys, I made a dumb post on Facebook. I'm not retiring anytime soon, but as you well know, I'm really, really old and probably can't keep working 7 days a week, 12 hours a day on pandemic time, but we'll try to slow down over the next few years. Danny Gilbert, she's not close to retirement, thank goodness. And so Danny will be with us and she'll take care of technical issues that we have today and look through your questions. So feel free to start filling up the questions box and Danny will handle those questions for us as we go through. If you're not a member of our Rural Health Clinic Information Exchange, please join. We have 3,100 members. You are welcome to post any information related to rural health clinics. If you're another consultant, you're more than welcome to put information on there related to RHCs. And if you've got webinars that are helpful at RHCs, please let people know because it's a good way to get the word out to everybody. Here is our website at ruralhealthclinic.com, and we've already posted all the slides on there. I know if you go into the handout sections, go to webinar, hates me, and half the time it will work and half the time it will not. Those little slide handouts, they will be available sometimes and sometimes not, which is why I posted these slides on our website here. So if you just go to ruralhealthclinic.com, certification materials, you will have those slides, or if you go to the RHC Information Exchange group, you'll be able to get access to them there as well. We do want to do a thank you to HSA for Health Services Administration, Health Services, I never can remember the name. I knew them with Ron Williams and all that. Ron Williams, you can tell I'm getting old. Ron Nelson back in the day, and Health Services Administration, I'll just say that. But Julie Quinn and their group for getting out some COVID policies as well. And of course, the National Association of Rural Health Clinics has some policies and procedures out there as well. Those are linked in here. So if you need those, there's access to that. And HSA just put out a new newsletter just an hour ago that has a really good summary of these rules as well. So we're trying to get the information out to you. Next 2 weeks, January 20th, we are having another webinar on cost reporting. So if you're one of our cost reporting clients, please sign up for that. And then the agenda today, I am supposed to take 3 minutes, and I'm right on 3 minutes right now, so I'm doing good. We're gonna have Charles James up next, and he's gonna do a quick sponsor message for 3 minutes. Kate Hill from the compliance team will give you the vaccine mandate, and we've got 40 minutes allotted for her. Patty and Jeff Harper from InquiSeq Consulting will show you some documents from InquiDocs that are really, really good. I looked at them this morning. I was like, oh, wow. I wish I'd have thought of this. So she did, her and Jeff did a really good job there. So we're going to show you a little bit about that because this is important that we really comply on the 25 states that CMS is starting to survey. We've got to move quickly, which is the reason for this webinar. And then, of course, we'll have about 10 minutes or so at the end for questions. So we'll probably run over an hour, a little bit over an hour, but we'll be able to answer those questions for you. So, Charles James, you want to take it for 3 or 4 minutes and tell us about North America?
Of course, thank you. Still have my picture with Seema Verma out there. That was fun, and unfortunately, fortunately at a Policy Institute, which we just heard was going virtual now, so we don't get all the personal interaction, but I guess it's better to be safe. North American, we're revenue cycle management, EHR hosting. Everybody asks on the listserv, hey, what's an EHR that works with rural health? And of course, we're one of them. We're dropping claims seamlessly out of our notes for rural health clinics all day, every day. So we'd love to talk to you about that. I don't want to just detract from the conversation here. I think really our sponsorship is really a kindness from Mark. Mark is really kind to collaborate and keep us all in a collaborative loop with one another. And I think the panel here represents that. So lots of really expert rural health clinic advice on this panel. I'm going to defer to them. You don't want to hear from me. Let's have Kate take it away. Thank you, Mark, for including us.
All right, Charles, thank you very much. Thank you for the sponsorship. And of course, our main speaker today is going to be Kate Hill. And we've all known Kate since she became a part of the rural health clinic world 8 or 9 years ago. Before that, of course, she was a war, and she's not going to say she's a hero, but she was. She is definitely a miracle worker for us. I know a lot of times when we're in a bind, Kate can bail us out of a bind. And so we're very thankful to how hard she works. She's another one that works 7 days a week, 12 hours a day, that wants to slow down a little bit. And definitely, her grandkids are too cute not to take a little bit of time to make sure you spend all you can with them. So Kate will be speaking for about 40 minutes or so. She's with the compliance team. She is over the RHC accreditation and probably some other things that I'm not familiar with. Of course, Patty Harper. Patty's with Inquisite Consulting in Louisiana, and Patty is just a wealth of information. Her and Jeff have Inquidocs, and Inquidocs is really just a fantastic way to keep up with your compliance and do reminders and do all the things that Inquidocs does, and all the changes. I know that's one reason why I've been reaching out to them, is because it's so hard to keep up with everything, and Inquidocs does that seamlessly and beautifully for you. So Jeff and Patty will be talking about that. And then we do have a panelist on here. Scott Robbins from Midwest Healthcare will be here to answer some questions for you as well. So let me move over to let me move this to Kate and let Kate take over. And Kate, I am shooting it your way, and you should have control of it now.
You got it. Okay, thank you. First of all, thank you, Mark, for the invitation to come present today. And let me be clear with everyone, this is all coming fast and furious from CMS, several memos a week at this point, with some challenging language. We'll just leave it at that, challenging language to decipher. So bear with us all. There's a great group of people here, a lot of good resources. All we want, all of us on this call and those listening from other consultants, is that you are prepared for this change, should it happen, and we'll talk more about that. So right now, this lecture does not include the following states. I'm not going to read that list, but you see it. So that's a good way, thanks to Steve on our team for putting that nice map together. So that's where we're not surveying, okay? And we'll talk more about that in a second. So you should all be familiar with the new addition to 491.8 at letter D, and that is all your COVID vaccination policies and procedures. I'm not going to read all this. I'm going to highlight a few things on this part for you, but it's for all employees, obviously, anyone that's regularly in your clinic, your students, your trainees, volunteers if you have them, anybody that provides care in your clinic, all right? And the staff who provide telehealth, if they never set foot in your clinic, would not apply to them. Beyond that, and there's another slide on that I'll share on some other people that may not be included. So your policies must ensure that all staff have received at a minimum a single dose COVID vaccine or the first dose of a primary vaccination series, depending on which they're getting, all right? So we're gonna start with that. And then a process for ensuring that you follow nationally recognized infection prevention control guidelines. So you can go to CDC. You've been doing this for 2 years. You need to have it in a policy by January 27th. And we're gonna talk a lot about dates today, but that's really very important that you're ready. You must have a process for tracking and documenting the status of all your staff. I'm going to recommend a nice spreadsheet for you for that. Probably Patty and Jeff have a tool for that. A process for tracking the boosters. Who gets the booster? It is not yet required, but I saw something this morning that's why that may change, but right now it is not, but you are required to track. So you'll have on your sheet who got the booster, all right? And then the process for tracking those exemptions that you've granted based on your policies, particularly for the religious exemption, all right? A process for tracking the information provided those who are been granted the exemption. So if you have going to grant a religious exemption, which everywhere I think and I say I think, except for New York, that is valid to have religious exemption. They have denied that in New York State for the time being. So you have to have a process for what you are allowing as a religious exemption. The religious exemption form is signed by the person unless your state requires differently. The medical exemption must be signed by an MD or DO, okay? And you're going to have this document. It's attached. You can read this. This is the actual law that was passed on 491-8D. All right. Now, temporarily delayed means a variety of reasons. Medical reasons, could be pregnancy, could be you've gotten the monoclonal antibody infusion, could be you've just been sick and you're delayed from getting it. And so you would need to track that by dates. Okay, so that's 491D. Now, 8D. Now, these are the states that will be surveyed as of January 27th, 2022. And the rest of them are held up in court. They're hearing oral arguments today at the Supreme Court, and I would love to be listening to that, but not to be. And so if you're in one of these states and you have a survey for any reason, it could be a complaint survey, it could be a reaccreditation survey, or it could be an initial survey. All of those are included in this, that you would be surveyed to this mandate. So January 27th, you have 60 days to come in compliance from that day on until February 28th, and it's only because the 27th is a Saturday. It's Monday the 28th. That doesn't sound right, but that may not be right because it wouldn't be only 28 days in the month, right? Now I'm confused. 30 days to come into compliance from February 28th. And then by March 28th, you must be 100% compliant. And there are penalties, quite severe penalties for that if you are not. So by January 27th, you are compliant if your policies and procedures are developed and implemented for ensuring all your staff is vaccinated and 100% of the staff have received at least one dose of COVID vaccine or have a pending request or have been granted a qualifying exemption or are identified as having a temporary delay as recommended by the CDC. You are great, you're good to go. You're non-compliant if less than 100% of your staff have received at least one dose of the COVID-19 vaccine or have a pending request or have been granted a qualified exemption or identified as delayed. That's non-compliant under the rule. The facility will receive notice of their non-compliance with the 100% standard. So you know what that is, the statement of deficiencies or the 1561, whichever it is. That's not the right number either. A facility that is above 80% and has a plan to achieve 100% staff vaccination within 60 days of January 27th would not be subject to additional enforcement actions. So you have time to come into compliance within 60 days of January 27th. And the degree depends on how many are vaccinated or unvaccinated, typical of condition level versus standard level. We'll talk a little bit about that in a bit. Now, by February 28th, you have to have policies and procedures developed and implemented for all staff, regardless of responsibility or resident contact, are vaccinated for COVID-19, including all required components of the policy procedures below, and 100% of the staff have received the doses necessary. So your policies are good and you're 100% compliant, same as before. You're good, you're 100% compliant, no deficiency. You're non-compliant if less than 100% of the staff have received at least one dose, and I won't read the same rules again. And you only have 30 days to come into compliance. This is where it got a little confusing. So you have 60 days from January 27th. So you see where this is going. By March, you are 100% vaccinated to be in compliance, all right? So remember that. So depending on when your survey is on the timelines here, the end goal is 100% vaccination by March 28th. So by March 28th, 2022, facilities failing to maintain compliance with the 100% standard may be subject to enforcement action. Within 90 days or thereafter of the issuance of the memo, which was last month, facilities failing to maintain compliance may be subjected to enforcement actions, okay? This does not allow for the 14-day waiting period. This is 100% by March 28th. So that'll play into play early on, but not as of March 28th. So they have to all be done, the second dose, by March 28th. So the policies must be implemented within 30 days of January 27th. by January 27th, excuse me, of the publication of this regulation. That's when we have to have it done. You must have a process for ensuring all staff have received at least a single dose. All right, we've got that for sure. The policy must ensure those staff who are not fully vaccinated or have been granted an exemption or have a temporary delay are intended to mitigate, have additional precautions. So this piece right here is from Appendix M, which is new. That's the COVID guidance for this regulation. So it depends on who's surveying you. If your states, I don't know how much they're going to go into the appendices, you know that from Appendix G and Appendix Z. So this is Appendix M, and I think Mark has that for you attached for you to have that. So you're going to have a policy on how you can keep your staff safe and your patients safe with those that are exempted or have not been able to be vaccinated. So what does your policy look like? That's what we're going to look at. I know. What are you doing to prevent that? You can reassign staff who have not completed their vaccination series to non-patient care areas, not easily done in a rural health clinic. You can require staff who have not completed their primary vaccination series to follow additional CDC recommended precautions, distancing, restricted areas, staff meeting rooms, kitchen, whatever. You can require at least weekly testing for exempted staff. Now that's going to be a challenge because testing is so hard to come by, and for staff who have not completed their vaccination series. Or you can require N95 masks for unvaccinated staff who have an exemption. So it's all about your policy. What does your policy say you're going to do to keep your patients and the rest of your staff safe? And that's really what it comes down to. You must track each member's vaccination status, any staff member who has obtained a booster, the staff who have been granted an exemption and what type of exemption, and the staff for whom must be delayed. So that's your tracking, and that I would seriously recommend a spreadsheet to track all these things to keep it easy. Facilities that employ contract staff who work full-time telework, so they never set foot in the clinic, this does not apply, all right? So these individuals may be subject to other rules, particularly the OSHA, depending how that turns out. Facilities have the flexibility to use any tracking tool they like, just have to have evidence for the surveyor to review. Additionally, facilities tracking mechanisms should clearly identify the staff's role, assigned work area, how they interact with patients. Most rural health clinics, this is pretty tight area, so I really wouldn't think that would come into play too much. Now, all RHCs achieve that 100% for their staff through the development of the policy to address vaccination. There may be infrequent services and tasks performed in a clinic that is a one-off kind of thing. If you're cleaning people come in at 10 o'clock at night and they're never interact with the patient or the staff, I would think that would be excluded. Here the government uses the example of an elevator inspector who comes in and out and verifies that your elevator is functioning properly, and they would be exempt. You're going to have to decide the frequency of presence, the services provided in your clinic to keep your patients and staff safe. So I think that would be in your policy. You must have a process by which staff may request an exemption. That's required. So that is one way or another, except New York on the religious. This process should clearly identify how an exemption is requested, to whom the request must be made, and a process for collecting and evaluating such requests, including your tracking and secure documentation of information. Obviously, all this is HIPAA compliant all the way, all these documents for sure. Staff who are unable to furnish proper exemption documentation must be vaccinated, or the facility must follow the actions for unvaccinated staff. And what is your policy going to say if there is a refusal to vaccinate without an exemption? And that's where it gets tough. And so there is one thing I saw, and I'll share that in a minute on another slide. Now, for the medical exemptions, this is really pretty well defined. It's on the vial, it's at the CDC. There's a website there, the summary document for interim clinical considerations for use of the vaccine. In general, a history of severe allergic reactions after a previous dose, an anaphylactic reaction would allow that person. But you must, in your documentation, specify which authorized vaccine is clinically contraindicated for the staff member. and the recognized clinical reasons for the contraindication. So this is done by an MD or DO. So that would be well spelled out in your policy. What are we recognizing? Or we're recognizing those listed on the CDC website, something like that to cover yourselves. A staff member who requests a medical exemption from vaccination must provide documentation signed and dated by a licensed practitioner. And it seems silly that it's in the law, but it does say it can't be the doctor asking for the exemption to sign his own paper. It's got to be somebody else. That makes sense to me. Must have a process to track and secure the documentation of that status of those who is temporarily delayed. So you would know, for instance, I had the monoclonal antibody and I can't get a vaccination, a booster, that would be for 90 days. So that kind of thing. You would know the date I had that and then when I would be eligible to get that booster, and that would be required in that case. Well, the booster is not required yet, but if it was vaccination status that was altered. In addition to medical contraindications, CDC recommends a temporary delay in administering the vaccination due to clinical precautions and considerations such as acute illness, and again, the monoclonal antibodies or the plasma for the COVID-19 treatment. For non-medical exemptions, such as religious exemptions, we direct you to the Equal Employment Opportunity Commission, EEOC, Compliance Manual on Religious Discriminations. I will add, there are documents on the NARC website. We urge you to go there and pull those down and see what that looks like. Surveyors are not, hear me well here, are not to evaluate your religious exemption process. You just need to have a process. We're not going to say, oh, that's not good. No. We look at the process, we're going to look at the sheet of paper signed by the individual and that the exemption has been granted. So put that sheet together. They are also on the NARC website, not the rationale. This is from CMS, that note. So that would be applied to accreditors and to the state surveyors. All right, we're just verifying that you did it by your policy. Now, while accommodations could be appropriate under certain limited circumstances, no accommodation is provided for staff that is not legally required. For individual staff members that have valid reasons for exemptions, facility can address those individually. An example of an accommodation for an unvaccinated employee with a qualified exemption could include the testing. I mentioned that already. Staff who have been granted an exemption should adhere to national infection prevention and control standards. So what are you doing? What have you been doing? You have been keeping your patients and staff safe for 2 years, almost to the day here, pretty close. And so what have you been following? You should have that in your COVID process policies anyway. So it's just going to be another piece of it in this one. For staff that are not fully vaccinated, you must develop a contingency plan for that staff. Now, we talked about this a little bit already. Contingency could include actions that you've taken that staff had indicated that they will not get vaccinated and do not qualify for an exemption. So again, what is your plan for those folks? Facilities should prioritize contingency plans for those staff that obtain no doses of any vaccine. And the plan should also indicate what action you'll take if the deadline is not met. So this is where it gets challenging, to say the least. Survey procedures. Surveyors will select a sample of staff based on current staff sample selection guidelines. So the states, the compliance team have guidelines on what our sampling looks like. And so we'll follow those same ones for your clinics. Surveyors should also examine the documentation of each staff identified. So if you choose 10 people to sample, then we're going to look at the direct care staff, the contracted staff, or the direct care staff with an exemption. And we're going to look at proof, such as a vaccination record card, documentation of the vaccination from a healthcare provider. We're finding with the provider-based clinics, that's all in the health, they've been given at the hospital of your hospital, and so it's all there in the record. And then the state immunization information system if they went to the state. Conduct follow-up interviews with staff and administration if we find any discrepancies in the process to determine if any additional doses were provided. For those identified by the REC as unvaccinated, surveyors will, and again, this is information that was given to us from CMS and given to all 50 states, review RHC records, determine if they have been educated and offered vaccination. I'm going to challenge you on that one. So what does that look like in your clinic? Have you sat your staff down and discussed this probably ad nauseum at this point. And what does it look like to tell me that you've educated your staff on why they should be vaccinated? Interview staff and ask if they plan to get vaccinated. If they have declined or have a medical exemption or contraindication, a medical contraindication or religious exemption. Request to see employee record of the staff education of the RHC policy. So that's your log. Remember, if you tell your staff but you didn't write it down, it didn't happen as far as the surveyor is concerned. So you have a little log, and we discussed this new policy on COVID vaccinations, and here's the people that attended. And it's a signature page, and it's dated and what we discussed, and that'll keep you out of trouble. Observe staff providing care to determine client compliance with current standards of infection control. And of course, we've been doing that for 2 years, well, long before that, but specifically to COVID, that's been ongoing and should be easily accomplished for you. Now, for those identified as unvaccinated due to a medical contraindication, review and verify all the required documentation signed and dated by the physician or advanced practice provider, which I found interesting. We're going to get some clarification on that one, and states the specific vaccine that is contraindicated for that person. The recognized clinical reason for the contraindication with the statement recommending exemption. Be very clear on that. The statement specifically says COVID vaccine is, we're recommending exemption for this person, signed by that provider. The levels of deficiency. For instances of non-compliance identified through the survey process, the level of deficiency will be determined based on the following criteria. From 30 to 60 days, we have to be at 80% for standard level. From 60 to 90 days following issuance of the memorandum, the expected minimum will be 90%. And then from 90 days on, it's 100%. That's your March 28 days. Now, I've heard some rumors, chatter about financial penalties. They do not apply to rural health clinics. So if you're a home health agency, hospice, or a skilled nursing facility, there are civil monetary penalties. They do not apply to rural health clinics. That was already in the law for those folks long before this COVID came around. So immediate jeopardy on March 28th is when 40% or more of your staff remain unvaccinated, creating a likelihood of serious harm, or you did not meet the 100% staff vaccination rate standard, observations of non-compliant infection control practices, and one or more components of your policies and procedures were not developed or implemented. That is, if you don't know IJ, we don't see it very often in clinics. We've probably only seen it a couple in 9 years, but that's a serious offense. It is the quickest way to lose your billing number. So you see how grave this situation is by March 28th, okay? Condition level, you did not meet 100% staff vaccination rate standard, and one or more components of your policies were not developed, or 21 to 39% of your staff remain unvaccinated, creating a likelihood of serious harm. Standard level, 100% of the staff vaccinated, and all new staff have received at least 1 dose, but one or more of your policies out of whack, or perhaps your infection prevention is not working well, and did not meet the 100% staff vaccination rate, are not vaccinated, but are making a good faith effort to come into compliance. So you see, this is the way it's laid out. Now, I'm questioning the condition level as I read that again for the 22nd time today, and I'm going to get back to you on that 21 to 39%, but I cut and pasted that. So it seems odd to me that 21 to 39 is condition level and 40% is immediate jeopardy, but I will promise to send something to Mark on that after we investigate that. So then there's a plan of correction. You know how that works. You get a citation, we write a statement of deficiencies, you do a plan of correction. To clear the citation, the RHC has met the requirement of staff fully vaccinated, either by obtaining additional doses or replacing unvaccinated staff with vaccinated staff, or the combined number of staff that are vaccinated have received a single dose or all of the doses on the multi-dose meet the requirement. The staff that has received at least 1 dose must also have their 2nd dose scheduled. So that would clear the condition level. To qualify for substantial compliance, but the citation remains at standard level, you have not met the requirement of staff vaccinated, but has provided evidence of the unvaccinated staff that have obtained their 1st dose and The remainder of the unvaccinated staff are scheduled, but it's not happened yet. So it would still stand as a standard level of deficiency. Now, to clear the IJ, the plan of correction or immediate jeopardy removal plans for noncompliance should be reviewed to ensure to include the following: correcting any gaps in your facility's policies and procedures, implementation of the facility's contingency plan that should include a deadline for each unvaccinated staff to have received their first dose of a vaccine, and implementation of additional precautions to mitigate the spread by the unvaccinated staff. That's it for now. Now, I know that already raised questions in my mind. How many times have I read this and I'm still having questions? So we are well aware this will raise thousands of questions. I'm going to turn it over to Jeff now and Patty for the next part, and then we're going to take your questions. Hold on one second, Jeff. It's coming.
All right.
Well, if I could find your name, it's a big list. Interesting. Hold on.
Well, while you're trying to find my name, we will go ahead and explain, as many of you that are in clinics have watched what Kate just did. She basically taking the CMS. Okay, can you?
It came. Patty's name was only one on the list. Can you get it to Jeff? Mark in the staff. Oh, there it is. I'm sorry. I do apologize.
Okay.
There, you got it. Now you got it.
All right, great. All right. Can you see my screen? Okay. Can everybody see my screen?
Yes. I'm going to mute
myself.
myself.
All right, great. Great. Kate, interpreting what the CMS has told her, she basically effectively threw most of us, our clinics, into deep water, and we're all trying to tread that water. Well, fortunately, we're trying to get you out of the deep water with what CMS has said, and so we're going to take a more practical side of how do we deal with what Kate just said. And so, and we're using our compliance platform subscription service to do that, which is IncuDocs. And we'll explain more, but right now we just want to help you get out of the deep water. And so the first question that we ask is, what do we need to comply with this mandate? And there are 5 things that we must deal with. Number one, we've got to have a policy that addresses 42 CFR 491.8D. We also need to have a vaccine tracking log. We also need exemption forms for both medical and religious exemptions. We also need a worksheet to both calculate and prove that we're in compliance. And then lastly, we need to show that we have given some educational handouts to our employees, especially those that are seeking exemption. And so here are those items. You see that there's a vaccination policy. In IncuDocs, that's going to be policy, well, it jumped past me. It's going to be policy 411. Over here, you see that we have a tracking log. Here you see we have a worksheet for calculating compliance. And then we also have exemption forms. And so the next thing
can we talk a little bit? Oh, okay, go ahead.
Okay, so what are the elements that need to be in this COVID-19 vaccination policy? Well, there's 7 things that we feel like that you got to have in that policy. Vaccination accessibility and administration, verification of COVID-19 vaccine requirements for the staff, management of employee for which vaccination has been delayed, management of exemption request, accommodation, infection prevention and infection control, record keeping and tracking, and enforcement for non-compliance. These are the 7 elements that we need to have in that policy. Did you want to add to that, Patty?
Well, I think after hearing Kate talk, we also need to make sure that we've got that education piece in the policy. But all I was going to say is we have chosen to put the vaccine mandate policy in our human resources section of our policies. That may not be where it best fits for you. It's going to depend on how your policies are organized now. So in our system, it seems to fit best in human resources as a function of employee health in most of our clinics. But if your policies are organized by the CFR, then you may want to put this policy where your other 491.8 policies are. So just because we put it in human resources, it made sense to us, but it may make sense to be somewhere else depending on how your policies are organized.
Good deal. That's exactly right. And in this case, we have written the policy to reflect both attachment M to the that was recently submitted plus 491.8.d. The third question that we have to ask is, what are the elements of the COVID vaccine tracking log? And if you think about this, we've already talked about this, and this is what Kate has already said. Well, we need to have a log that keeps up with the employee or the contractor's name, their role and their hire date, the date of the dosage, and the manufacturer of the vaccine. Now, and that's because certain vaccines don't have but 1 dose, while other vaccines have multiple doses necessary. And we need the dates of each one of those. We need those exemptions that have been granted and the type of exemption and the date of that exemption. We also need to know on this roster of employees which ones are 100% remote or are they all on site, because that's going to determine how we calculate compliance. And then those employees that have a temporary delay, along with the dates of those delays, and that was discussed already. And those delays could be because of existing illness or a recent infusion, and the CDC has given guidance on that. And here is the actual, this is in the library of IncuDocs. We have this tracking tool where you keep up and put all this information in with dates. Now, this is used in conjunction with the next tool that we have, but this is the tracking tool. This is something that Kate and her staff, when they came to come to survey you, would want to see, okay, who is the person, what doses have they had, what exemptions have they requested and been approved. This is the kind of information that they're looking for.
So Jeff, can I add something?
Yes.
So when we go back to the log, if your nursing department, if you're a provider based within a bigger organization and your nursing department is going to be keeping up with this as a function of employee health, they may have a separate spreadsheet that they use. They may actually have software that they use to track things like hepatitis B and TB. So remember that the RHC is responsible for their own employees, even if they're part of a bigger system. So you're going to want to be in communication with those people within your system if somebody is going to be helping you track this that is outside of the rural health clinic. So there needs to be really good communication, and you need to understand their process. You don't need to just hand it off to them and say the hospital's taking care of it.
Good point, Patty. In fact, we find that in most of our provider-based clinics, any time that a clinic says, oh, the hospital is going to take care of that responsibility, we end up usually having a problem. And I'm sure Kate could address that too, is that many times our clinics are not, well, let me put it there, sometimes they're stepchildren in the family, and therefore the hospital who has responsibility or who has agreed to have responsibility doesn't always take that responsibility. And so the clinic is still responsible. So that we have to watch and make sure those things are done. In addition to that, we have requirements. What are the requirements for employee exemptions? Kate went over those things, but there's two types of exemptions. And to make sure that we're consistent and we don't communicate the wrong thing and we treat all of our employees equitably, we recommend that you have these forms, that everyone gets those forms if they choose to request an exemption. And there's a separate form in the library of IncuDocs for both medical and religious exemption. And as it's already been stated, the medical has to be signed by a DO or MD, that only the employee or contractor signs the religious exemption. And once again, these are in the library under 411A and 411B. But
So,
go
I'm
ahead,
sorry.
Patty.
We're in the same place, and so we're getting a lag, so we're not trying to talk over each other. I'm sorry. So what you need to understand too is there are steps to this. The employee requests the exemption, but the employer has to formally grant the exemption. So just having somebody hand you a request form is only part of the process. And so just understand that, somebody just can't give you a piece of paper back. You have to actually, as the employer, grant that exemption based on what your policy says the criteria for granting those exemptions is.
Good point, Patty. And in fact, each one of these tools that we're showing you that are in IncuDocs are all predicated on you having a complete policy that addresses all these things. And in fact, as many of you know that have IncuDocs for your policy and subscription service, we try to minimize the amount of volume in each policy. We would like to have it where policies are 1 or 2 or 3 pages long. Well, this policy is 5 pages long, unfortunately, but this is some unprecedented things that have come down in 491.8.d, and so it takes that kind of volume in your policies to address everything. Well, then how does the clinic prove or calculate compliance? Now, this is the situation that it gets interesting. The compliance team or one of the other accreditors or state surveyors come into the clinic and they have to calculate, are you in compliance? Well, it is best if the clinic already knows whether they're in compliance or not. And so we suggest that every 30 days in this process for the first quarter of 2022, that the clinic is calculating their compliance. And so we have made this worksheet. Now, what this worksheet does is it simply, on the 27th of January, on the 28th of February, and on the 28th of March, these calculations need to be done. And you're taking your total staff, you're subtracting all the staff that are totally remote, so that gets you the net impact in the clinic staff, and then you add up the number of staff that meet the vaccine threshold, plus the number of staff that have a valid religious exemption, plus the staff that has a valid medical exemption, and include also the number of staff that have been granted temporary delay, as is recommended by the CDC. And you add those numbers together and then divide by the net staff that's in the clinic, and that gives you a percentage. And we know that the grace period, which is the first period, it needs to be 80% or higher. In the less grace period, which is what we call the February 28th time period, it needs to be 90% or higher. And then the no grace period, which is the March 28th, which it needs to be 100%. But you could use this worksheet to make that calculation. And in fact, these numbers all come from that tracking tool that we filled out. So we fill out the tracking tool, and then we take the data off that tracking tool, drop it into this worksheet, whether you're in the grace period, the less grace period, or the no grace period, and you make the calculations. I believe that when Kate and her staff are surveying, if they came to you and saw this, they would just audit your calculations and see that you followed properly, because that's what they're going to have to do, is they're going to have to do this same calculation. And so we feel like that now this is also in IncuDoc's library. Should the clinic assist in educating their staff on the details of the two exemptions? Absolutely. To be fair, consistent, and balanced, we need to have handouts, and they should be prepared and given to each employee so that they consider their options. We don't want any employee to ever say, I didn't know, or you didn't tell me. And therefore, we think that you need to guide them or give them direction to both the EEOC and the CDC so that they can determine, especially in the exemptions, what their position is and what they should be able to do and how to do it. And therefore, also in the library, we have educational resources for the employees and the employer, which gives you the ability to go to the EEOC and see the technical assistance there, and also go to the CDC. Okay, that alarm just went off to tell me that we have now used our 15 minutes. And so without any further ado, we're going to give it back to Mark. We're going to give it to you.
Okay. Thank you, Jeff, Patty, and Kate. That was amazing. You guys did a great job and made it to where we can make this manageable. I mean, it's going to be a hard thing to do because we got to do it very quickly, but I think we're going to. You've given us light at the end of the tunnel to where we can comply with this. So I appreciate that very much. It is now time for questions. Danny, if you'll start pulling those together. I'll go ahead and get started because I got some email questions yesterday. Yes?
Can I just make 2 comments because I don't want to get them.
Go ahead.
One is I just had a read from our team that we believe the provider must be an MD or DO. We call providers NPs because they are PAs, but we think CMS wants MD or DO on the exemption, medical exemption, number 1. Number 2, I just want to comment, if you're in the 25 states where this isn't impacted on January 27th, keep your ear to the ground, because anybody's guess whether this is going to go to all 50 or go away. There's no way to know that right now. So don't just ignore this. If you could start getting some policies together, whatnot, you'd be wise. So you're not caught short-handed. I just wanted to say that before we got into questions. Thanks.
Okay. All right. Thank you, Kate. And also, Nathan and Tressa, I made you guys panelists. So you've got an open line. If you want to say anything, just unmute your line and start talking, and Danny and I will shut up and let you say whatever you want to. So let's go ahead and Scott, I'm going to give you the first question here. We have a LabCorp employee, phlebotomist, who is assigned to our facility. They do check-ins and they see patients. Will they be required to be vaccinated or have some type of an exemption?
The way I understand that at this point, if you're contracted, you are going to be required to have that vaccination or exempt. I mean, you can still consider those exemptions with the clinic that you're working out of. But absolutely, there's going to be that consideration as part of the requirement.
Yeah, that was my thinking as well. I was thinking, well, because they have time with the patient, with your employees, they're going to need to be vaccinated or have an exemption. Is that, Kate, is that the way you would interpret that as well?
They're in the clinic every day. I don't see any way around that one.
Okay. All right. Now this one gets a little bit more confusing to me though. And Scott or Kate, if y'all want to handle this, or Patty, do I have to require the cleaning staff who are W-2 employees, but they come in only after hours, have no face-to-face contact with patients or employees? Will they have to get the vaccine or an exemption as well? Scott, what do you think about that one?
I think that you're stepping into some gray area, but I think somebody who's in there with surface contact every single day, I would feel the safe side is to put that out there to be vaccinated or exempted. But I do think there's a reasonable question if you're not in front of patients, but you're in the clinic still.
Yeah. Kate, do you sort of agree with that? That was my answer that I emailed back to him, but I wanted to, because I thought the same thing.
It's a good question. I'd like to hear more.
Yeah.
Yeah, like we have answers to that. It's your policy. You write it, and there's no contact with anybody in the clinic. They're wiping things down and leaving. I would see it one way, but it's your policy and procedure. So you decide that and put it in writing, and then you should be good.
Okay. Yeah, it's a great.
No question, just no question at all.
Same might be applicable to like a care management nurse. A care management nurse is not in, but making calls and coordinating.
Remotely making those calls, right?
Pardon me?
Is she remotely making those calls or in the clinic space?
Yeah. So
yeah, she wouldn't be applicable. I mean,
yeah. And basically with where we are in this rule, I would suggest that if you have somebody that doesn't necessarily have to be in the clinic, like a care management nurse, I would have her some off-site to just make it a lot easier, because if they're not on site, we don't have to put them in this calculation.
Yeah, I think that's important. If you have remote billing people, remote chronic care management people, that is a safe harbor for this rule, is the way I understand it. So, and then the last email question I got was, this one's gonna be, this one will be a fun one. Have a senior owner physician who's 82 and who he ain't taking that vaccine. How do I get my staff to comply with the vaccine mandate when I cannot get the owner of the practice to comply? So I don't.
Oh my goodness.
Yep. Yeah.
That's where the education handouts and training comes in, I guess, would be my answer.
Yeah.
What's the reasoning behind not taking it? If you have a legitimate reason, then I would think that's reasonable.
If he does not have an exemption and he's in that clinic seeing patients, you have a serious problem. That's how I read this. Serious problem.
Yeah, that's it. Okay, Dana, you want to read some of those questions for us and sort of allocate them to people?
Sure. The first one is from Deb. She says, if we're fully compliant with our Oregon vaccine mandate, is there anything we need to do additionally?
So it always comes down to which is the higher standard. So I'm not right on top of Oregon's rule. I know they are mandated, same as Colorado and a few other places. So if there's something more strict in this, you have to comply. Okay. And if like Florida, it recognizes immunity as an exemption. The federal government does not. So you have to go with whichever is high. If you're in Florida and you're exempted because you've got antibodies, that's not going to work if you have a state survey.
Yeah, Kate, the way I would look at this would be, you are required to do these policies. So your CMS surveyor is going to come in and survey you on those policies. These policies are probably not in the Oregon law. So I would look very closely at these CMS rules and try to implement those alongside your Oregon rules, which again, I don't know the Oregon rules either, but it just seems like you're going to have to pay attention to these CMS rules.
Right. It's kind of like oversight, physician oversight. Some states have rigid, some states have none. We all have to live by 491.8, whatever it is, the number. So it's the way, whichever is higher. Washington State, they don't like oversight, but they have to do it to become a rural health clinic.
Okay, Dan, you got another one?
Yes, sir. How do we handle new hires? Do they have to be fully vaccinated before they start?
Ooh.
Before they
I
start in
think
patient
it
care,
says
yes.
they have to be vaccinated before they have direct patient care.
Yes.
March 28th, you can't hire them. Right now, you've got some leeway, but March 28th, you're not going to hire them until they're fully vaccinated, or you're going to have a problem.
That's right.
That's the way
Yeah, it's all based on dates. It's all based on dates.
dates.
And-
A new hire right now has a different rules than a new hire a quarter from now.
Exactly.
Well, and I
that's
think when you
challenging
write your policy, you need to think that maybe there's going to be a different process for new hires than there is for existing employees. You know, just depending on how the workflow is within your organization, because HR is going to have that. They're going to drive that more than employee health, but everybody's going to have to collaborate.
The challenge is going to become as we get into February, closer to March, when if you have to let somebody go, and you got to hire that new person that's vaccinated, or you're in the same spot you were before, and so it will be a difficult winter.
Thank you. David says, I have a stellar rock star front desk check-in person. She does not see patients other than through a window. She's adamantly opposed to the vaccine. In your opinion, would an N95 mask and weekly rapid testing be an acceptable mitigation strategy to keep them employed?
My heart breaks for all of you. These are such challenging times. Based on the regulation, I don't think that's going to work for her. There's no exemption. There's no vaccine.
It'll work until March 28th.
Yeah.
And she can be part of the 10% up until March 28th. But on March 28th, we don't have any leeway unless you have an exemption.
Okay. Do we need to have a physical copy of the vaccination cards with our HR files?
That's right, in the guidance, it says a good photo of it. Now, if they're in your hospital health employee section and they got their shot right there, you just pull up the record. But if they went elsewhere, then you have to have some proof. You have to have proof. So it's a picture of the card or the whatever copy of the card.
To kind of go off that, Kate, somebody else said she had printed out staff vaccines from the state immunization registry site. Will that be sufficient?
Oh, yes, absolutely, sure.
Okay. If a contractor to the clinic has an exemption from his or her company, does that count for an exemption in our clinic setting?
Oh, that's a good question. That's a great question.
That is a great question. I'd say no. Well, you mean they have a medical or a religious exemption? Then you could honor it, I suppose. Anybody want to take a read on that?
But it won't be from the clinic. The exemption will be from the other employer.
The information provided might be able to lend towards it, but you're going to have your own policy and process, and you're going to have to follow that if there's any differences, but you're still going to need that information as evidence of compliance.
So perhaps in our policy, we say, and I'm just winging this one, we honor the exemptions of our contractor companies or something to that effect, so you're covered. Because if they have a valid religious exemption or medical, how could you, especially the medical, how could you not honor it because they work with you? I would have a way to protect them and protect your staff and patients from them.
Yeah, that's true. But on the religious, some employers are just taking them at good faith and some employers are challenging them. So if your contractor had a different way to grant religious exemptions than you did, you'd have a rub there.
So I'd want to see their policy, I suppose, to verify that that was valid for us. If it didn't match my policy for religious, right? Something like that, maybe.
I think the policies that each clinic has are going to be critical on how we evaluate all of these one-off situations. The policy, being a rock solid policy, is going to be our key in this process.
Okay, thank you. Can an NP complete medical exemptions and document contraindications?
We don't believe so. That was a read from our team. They use the word provider mostly for MDs and DOs, and somewhere in the guidance, it actually says MD. So we're going to say no to that one right now unless something changes.
Okay. If everyone in your office or clinic is vaccinated and has proof of such, and you don't plan on hiring anyone without a vaccination, does your COVID plan still have to have mitigation and other non-applicable components?
Yes.
Yeah, you got to read 491.8 and be in compliance with all those.
Yes. And just because you have a stagnant or stable workforce does not mean you don't need to be prepared for the contingency that you lose someone in that workforce. And so not having a policy that addresses all those things is grossly inadequate.
Right. Let me throw in here that Cindy just on our team just commented, and this is a good one. New hires now prior to March 28th just have to have the first shot and the second within 30 days. So that'll work in January, February, depending on your dates. Okay, so you can hire somebody now that has first shot and just follow through with the second, and you'll be good. And that wouldn't be a deficiency before March 20th.
Now, Kate, from our reading of this, it looks like that the first grace period you can get by with one dose of a 2-dose vaccination, but both the second and the third testing period, it takes a full dose, both doses, if it's a multi-dose vaccine.
Probably because if you hired somebody on February 27th or 8th, you don't just have 30 days to squeak. So any day thereafter, it's no good anymore, right? So you just have to watch your 30 days before March 28th.
So to that, when you're writing your policy, you want to be careful you're writing it to 491.8D and not just to the phasing in guidance, right? Or you're going to have to go back and redo that policy when after March is over. So maybe have a supplemental document that outlines the phase in or an addendum that's the phase in, but you don't want to have to put all those dates in your policy now, and then at the end of March, you have to redo the whole policy in its entirety.
Danny, you got another question for us?
Yes, sir. Going off of the new hire, Caitlin asked, are they allowed to apply for an exemption as well? New hires.
Back to your policy. What's your policy?
How do we handle a drug rep that comes into our clinic to speak with the providers regarding their drugs they handle?
So in that one guidance, it said regular visitors coming in. You know, these are just, these are on the edge. Where do you guys think of all these things? Oh my goodness. You know, if you think about why this is happening to keep people safe, I'd be surprised if I haven't talked to any drug reps recently, but why the company wouldn't require it. They're drug reps, for crying out loud. It's what they do. But I don't know the answer to that. Anybody else have a read on that?
I agree with you, Kate. If it's regular, I think that they have to be
regular. Yeah. So
vaccinated.
It's your policy. Regular visits to this clinic. Do they come every 6 weeks and bring samples? You know, they're hanging out in your drug room. They're not vaccinated. Who knows? Have you screened them?
Yeah. Yeah, they could.
Are they bringing lunch once a month? Yeah. Are they bringing lunch once a month when they come?
Yeah. There's too much interaction there, and just think of what could happen if someone comes in with COVID into your staff, and you have staff members that have been exempted by either religious or medical. You've got a major problem on your hands, and the whole idea here is not just to comply with the mandate; it's to keep our staff and our employees safe. And so if I've got a guy, it seems like every time that we come into a clinic, there's a drug rep serving lunch.
Well, that's how you get the attention of the doctor. You'd never get to talk to him.
Yeah, or a home health person or a lab person or another vendor.
But listen,
we're
even not just the exempted staff. This is the vaccinated staff. If somebody comes in and they're sick, I got COVID after a vaccine. So, you know.
I did.
Yeah, exactly
so
right.
Did I.
Many of us are in that state, so we would all be at risk in the clinic. So I think that kind of answers.
That's right.
He can drop them at the door and go.
I also got sick after vaccinated and boosted, and it's been as ill as I've ever been in my life. So I'm pretty sure it kept me out of the hospital. But different question.
Yep.
True.
All right,
So,
Dan, you got any more? Because we got to get off here pretty quick here. We're at 2:05 Eastern time, so we don't want to.
One thing I didn't say earlier, for those people that have IncuDocs subscription service, all of those tools that we just went over are in the library under 411A through E. And so if you're looking for those items, go to the library and they're already there. Okay. I'm sorry, I just didn't say that.
No, and then I think we did have one question in there. It says, if you're not an IncuDoc subscriber, which you should be, but if you're not, is there a way to get that Excel spreadsheet and maybe the other document there, the vaccine, sort of keeping up with everybody? Is there a way to get that?
Mark, yeah. Piggyback on that question, because it kind of goes hand in hand, is somebody did ask, is there a cost to obtain the templates? And I guess they kind of want information on IncuDocs.
Well, if you email either Patty or I, we will be glad to do one of two things: give you the price of IncuDocs, or even Charles, is that as far as that goes. And as far as the document itself, ask us what you want, and we'll see if what we can provide for you, because we do want to help everybody meet this requirement.
Let me just say there, we as accreditors are not permitted to give you policies and templates. That's just the mandate we have. But Scott at Midwest Healthcare, if you work with them, they have policies. Julie Quinn is listening. She has a full set of policies, and Tressa is listening. So all the consultants have policies, and Mark for sure. Mark there has
some. Yeah.
And exemptions too, exemption forms. Everyone has those too. And in fact, HSA has a good exemption forms on both medical and religious exemptions.
And they're on the NARC website as well. So don't forget that. That's an important place to go.
Yeah. And I did post a link to that. So both the HSA website and the NARC website where those policies are as well. So Charles,
did you say Nathan was listening?
He was, but he's gone. He probably had to bail out from another meeting.
All right. He made some interesting comments to me yesterday about the Supreme Court, and I don't dare quote. I'm sorry I didn't get to that earlier. That's a shame. But we just have to wait and see. He did say this: because they took the case so quickly, they don't do this where 2 weeks ago or something they signed somebody up for oral arguments at the Supreme Court. It just doesn't happen. You got to get on the docket, right? He did say because of that, he feels it should be a quick answer, but the answer will only be whether we can hold it up right now, not whether it's right or wrong, the mandate. So it's very complicated, and that's why I should have gotten him first. Sorry about that. He's far more up. I'm not up to date on the Supreme Court.
Yeah. Anything else, Charles? Did you have something before we headed out?
Just to say thank you for gathering us all as always, and thank you to the expert panel for your interpretations and advice.
We will do our very best to keep you all posted. This is a great group of people, including those listening from the other consultants. And Mark, watch Mark's Facebook page, NARC's Facebook page, and as we get news, we'll share it for sure.
Yeah. Okay. Well, thank you, Kate, Charles, Scott, Patty, Jeff. Everybody, we appreciate you very much. Y'all stay safe. I think the weather is supposedly coming in. I saw where a couple of people had to leave because of snow, so stay safe. We don't want to have another Virginia situation where we're stuck in cars for 2 days. That doesn't sound like a lot of fun. All right, well, thank y'all. Bye, everybody.
Thank you.
Bye, everybody.
Bye.